New England Comparative Effectiveness Public Advisory Council, where we will be considering the effectiveness and value of emicizumab for hemophilia A. My name is Rob Azeltine. I'm professor and chair in the Division of Behavioral Sciences and Community Health at the UConn Health Center. And at the beginning of the meeting, I'd like to invite the CEPAC panel to briefly introduce themselves and where they are affiliated.
Good morning. Is that on? Good morning. My name is Stacy Brown. I direct the Community-Based Education Office at the UConn School of Medicine.
My name is Jason Wasf. I'm a cardiologist. I'm medical director of the Physicians Organization at Mass General and director of outcomes research at the Mass General Hospital Heart Center.
Jean Ryer. I'm director of the New Hampshire Citizens Health Initiative at the Institute for Health Policy and Practice at the University of New Hampshire.
My name is Teresa Fama. I'm a rheumatologist at the University of Vermont Health Network at Central Vermont Medical Center and the medical director of specialty care there.
Good morning. My name is Kim Lenz. I'm the clinical pharmacy manager for the Massachusetts Medicaid program and assistant professor in family medicine at the University of Massachusetts Medical School.
I'm Austin Fracht. I'm a health economist, and I'm the director of the Partnered Evidence-Based Policy Resource Center at the VA Boston Healthcare System.
I'm Claudia Gruss. I'm a gastroenterologist with Western Connecticut Health Network. I'm also chair of the Quality Committee for CT HealthLink, a health information exchange.
I'm Roger Snow. I'm an internist recently retired from Mass Health, the Massachusetts Medicaid Agency.
I'm Chris Jones, health economist and ventures investment officer for University of Vermont Health Network.
Steve Kogut. I'm a professor of pharmacy at the University of Rhode Island, where I direct our graduate program in health outcomes research.
Hello, I'm Al Whitaker. I'm the Northeast Region Director for Community Health Strategies for the American Diabetes Association.
And I'm Julia Prentice. I'm the Director of the Center for Access Policy and Evaluation Research in the Department of Veterans Affairs.
Thank you. At this point, I'd also like to ask members of our expert panel to introduce themselves.
My name is Sanja Wilkes. I'm the Associate Director of Advocacy for the Hemophilia Federation of America, but I'm not here in that role today. I'm here as a mom of a severe hemophilia A with inhibitors, 14 years old.
Hi, good morning. Mark Skinner. I'm an attorney by profession. I live with severe hemophilia. I've had a variety of leadership and community roles, including with the National Hemophilia Foundation and the World Federation of Hemophilia.
My name is Dr. Stephen Pipe. I'm a pediatric hematologist. I'm a professor of pediatrics and pathology at the University of Michigan. I also direct the pediatric program for our Hemophilia Treatment Center, and I also serve as chair of the Medical and Scientific Advisory Council to the National Hemophilia Foundation.
Good morning. My name is Margaret Ragney. I am a professor of medicine and clinical translational research at the University of Pittsburgh, and I direct the Hemophilia Center of Western Pennsylvania in Pittsburgh, Pennsylvania. I have many disclosures. I do much research with many companies, and I think I won't list them all. I think that's in your brochure.
Thank you. Thank you for introducing that topic to us. At the beginning of every New England CEPAC meeting, we want to ensure that all speakers disclose any financial relationships with the health industry. Every member of our New England CEPAC panel who is present today has met the ICER conflict of interest policy. Are there any updates to this from the New England CEPAC panel? No, thank you. Expert panel members, could you just comment on any potential conflicts?
I've done research with Onalam, Biogen, Bioverativ, Bayer, Shire, Novo Nordisk, many companies. I have not done research with Hemlibra, but I've served on their advisory panels.
I have current funding from Shire. I've had This is for basic science research. I've had also basic science grants through Pfizer. I serve on steering committees for several companies engaged currently in gene therapy for hemophilia, and I've had consultancies to most of the hemophilia therapies in time past. And the thresholds, I think, were part of our disclosures for the meeting. Yeah.
Hi, Mark Skinner. I have nothing new to add to what's printed actually in the report. I've received honoraria for consultation with Hoffman LaRoche, Bayer, and serving on Blue Cross Blue Shield's medical advisory panel. I do have stock holdings in the health sector, but none of which relate to hemophilia products. I am an individual with severe hemophilia, which I also usually acknowledge as a potential conflict. I'm president of the World Federation of Hemophilia. I serve on MASAC and the Athens, our national registry board. And I have research funding from a variety of companies for the patient outcome work that I lead, from Baxalta, part of Shire, Bayer, BioVerity, CSL, Novo Nordisk, Roche, and Sobi.
And Sanja Wilkes, as I said, I am an employee of the Hemophilia Federation of America. We receive funding from multiple pharmaceutical companies, but I don't have any other personal conflicts.
Thank you. Other speakers today, including our policy roundtable participants and individuals making public comments, should announce any financial relationships with the industry when they speak. We will also present this information publicly on slides. Before I turn the meeting over to Dr. Steve Pearson, I'd like to allow Dr. Milonakis to introduce himself.
I apologize for being tardy. My name is Lefteris Milonakis. I'm the Director of Infectious Diseases at Brown University, and I'm a practicing infectious disease physician.
Thank you. And I'd like to introduce Dr. Stephen Pearson, President of ICER.
Good morning, everybody. Thanks for being here. I'm sorry we couldn't offer you a succulent as the conference next door did, but hopefully we'll make it worth your while. Thank you, Chair, and welcome to all of you here and watching via webcast, and a special thanks to our clinical experts and patient representatives for being part of our meeting today. So why are we here today? As is often the case, we're here because there is new innovation in the health system that is promising truly substantial benefits to patients and their families. I found a lovely quote from a stat article just a few months ago in which a mother was talking about her son. Her father, or grandfather, I forget which now, had hemophilia, and she remembered how difficult his life had been, how careful he needed to be. And she commented about her 3-year-old, he's wild. He's probably sometimes the roughest of them all. He leads a totally normal life. He plays t-ball. He'll start soccer in the fall. He runs and jumps and wrestles with his brothers. It's just a lovely statement of what innovation can bring to the life of patients and to their families. At the same time, the system often struggles with innovation in a variety of ways, and one of which is cost. And these come also from relatively recent publications. In one fact, in 2015 alone, it says Medicaid paid about $353 million for prescriptions for the most commonly prescribed blood clotting medication for hemophilia, which was a 273% increase in spending from just 4 years ago. Another quote from this same article, and we'll address this later this afternoon, was apparently just an understanding, a widely viewed fact of life. Generally speaking, the price of hemophilia drugs rise as rival drugs hit the market. And we know that this isn't just a system issue, it affects patients and families. And a quote from the Hemophilia Federation of America and National Hemophilia Foundation letter says that patients with hemophilia, particularly inhibitor patients, are consistently worried about the cost of treatment. So, as is often the case, again, treatments with new mechanisms of action often raise exciting new questions about how they can be applied to improve patients' outcomes. And they also raise questions about appropriate use and cost. And so we feel that there's a really important need for objective independent evaluations and public discussion of the evidence around the effectiveness and the value of new treatments. The goal of all of this is really to help our health system accelerate in its transition, which we truly hope it's already on the way, but it's not all the way yet, to a sustainable healthcare system in which all patients can be guaranteed access to innovative, high-value treatments. So you've heard introductions of the members of the New England CEPAC. They are an independent appraisal committee that we convene to do this work in public, not behind closed doors, not in a way that hopefully the public can't access. This is to be a public meeting in which all stakeholders can have a voice. I want to talk about the background of the academic work, the report that went into this kind of the foundation of the meeting, and I'll tell you about the Institute for Clinical and Economic Review that is the source of that report. So first, we are an independent, not-for-profit research institute. The sources of our funding in 2018 are shown up there. These are all sources of revenue for the organization. You can see that 78% come from not-for-profit foundations. The chief funder there is the Laura and John Arnold Foundation. We also receive funding from the California Healthcare Foundation, the Blue Shield of California Foundation. We have a very small sliver of state contracts. And then we have about 20%, a little bit less, that we have for a specifically separate policy summit program in which we take direct contributions from manufacturers and from health payers, both health plans and PBMs, to run a summit where we convene leaders to discuss evidence policy. The report today was developed through a long process. It takes about 8 months, where we start with what we call a scoping phase, where we reach out to get guidance from patients, the patient community, clinical experts, and the manufacturers to try to get our bearings and understand what are the key questions, what are the key issues that matter most to patients, and how do we produce a report that will really inform decision-making and make sure that we identify the issues clearly. Then we have an internal ICER staff evidence analysis, a systematic review of the available evidence. We look for all kinds of evidence, RCTs, observational data, data that may not yet be in peer-reviewed journals. We hope often to find patient-reported outcomes and other sources of information to complement that. We also work with outside academic colleagues. In this case, it was folks from the University of Washington, and they helped design. They were the leaders in designing a cost-effectiveness model to help us evaluate the long-term cost-effectiveness. This goes through multiple iterations of public comment and revision, and we also have specific expert report reviewers, and in that case, 2 of them are at the table with us, Dr. Ragney and Dr. Pipe. I'm sorry, all 3, and Mark Skinner. So how is the report ultimately structured to try to support the kinds of deliberations that we hope to have around effectiveness and value? So I want to just show you a brief schematic of the value framework that underlies the report, and in our minds, the deliberation in many ways. So with that goal of sustainable access to innovative high-value care, we think there are 2 important elements that you need to think about to achieve that goal. The system needs to think about long-term value for money, and I'll talk more about the components within that concept, and it needs to think about short-term affordability, because sometimes, not always, but sometimes those 2 can be in conflict. And it's helpful, we think, for us to have public meetings where we may wrestle with some of those conflicts. But we spend a lot of time talking in these meetings about the long-term value for money, and that itself is made up of 4 subcomponents, if you will. One is the comparative clinical effectiveness, which is where we'll start off when the evidence is summarized, looking hard at that issue. We obviously also do a discussion around the incremental long-term cost effectiveness. And we'll have discussion and votes on potential other benefits or disadvantages and contextual considerations. These are elements that may not be captured by the clinical evidence as it exists today or by our ability to model it in a cost-effectiveness model. But as you'll see, there may be some important potential other benefits, for instance, and contextual issues that we want to make sure are part of the public discussion around value, because it should influence the way that patients, clinicians, and policymakers think about long-term value. The short-term affordability is supported primarily by an analysis of the potential budget impact of new costs or new interventions, I should say, in the healthcare system. So we'll be talking about that as well. So the agenda for today is structured so that we will be done by 4 o'clock. We will start with a presentation of the evidence by Dr. David Rinn, the Chief Medical Officer at ICER, and then the cost effectiveness from the faculty at University of Washington. There will be a dedicated time period for manufacturer public comment at approximately 11:15, followed by public comments and discussion. Lunch will run for about 45 minutes, and then we'll come back here at 1 o'clock for a deliberation specifically guided towards the votes that the New England CEPAC will take on questions about the strength of evidence for clinical effectiveness and value. A policy roundtable will start at 2 o'clock, in which the clinical experts and the patient community representatives will be joined by representatives of the payers community and by manufacturers. And that's where we will, in a sense, jump off from a discussion of the evidence to talk about what are the implications for future research? What are the implications for coverage, for pricing, for payment of providers? How do we get this right so that we achieve that goal of using evidence to support sustainable access to high-value care? And we'll have a final session of reflections from the CEPAC members and the policy roundtable members, and we'll, as I mentioned, we'll adjourn by 4. So welcome again, and with that, I will hand it over to Dr. David Rinn, ICER's Chief Medical Officer.
Thanks, Steve, and good morning. I just wanted to point out key members of our review team: Felucia Agbula, Alexandra Ellis, Aksum Agal. We have no disclosures of interest relevant to this report. I also wanted to thank the clinical experts, including Mark Skinner and Drs. Pipe and Ragney, who were incredibly helpful in helping us work through the complexities of this topic and the many versions of this report. I'm going to spend just a few minutes again getting into what we're talking about today for background, because this is such a complex area. This is the clotting cascade. In the shaded blue area there is the action of factor VIII becoming activated factor VIII and continuing the clotting cascade along. We're talking about hemophilia A, deficiency in factor VIII, which results in increased tendency to bleed. It's an X-linked recessive disorder affecting about 1 in 5,000 male births in the U.S. Patients are at risk for life-threatening bleeding, and this isn't always recognized, except for those who are aware of the condition well. Bleeding into joints in particular, joints and muscles, but joints in particular, can lead to disability, and this is a substantial piece of the problem of patients who have severe hemophilia A. Bleeding into joints both seems to trigger additional bleeding into the same joints and causes progressive damage to those joints over time. Prophylaxis is available for most patients with hemophilia A. Factor VIII became available for home treatment of bleeding in the 1970s and became more and more frequently used for prophylaxis until, by the early to mid-2000s certainly, it was routine to at least recommend prophylaxis to patients with severe hemophilia A. And by the mid to late 2000s, randomized trials had demonstrated efficacy of such prophylaxis. In about 1/4 of patients who are exposed to factor VIII and have severe hemophilia A, and I'll just for a moment mention that severe hemophilia A refers to hemophilia A with factor VIII levels of less than 1%. It's not actually a clinical diagnosis, although it tends to correlate with clinical phenotype. In about 1/4 of such patients, antibodies that inhibit the action of factor VIII develop. And these usually develop early on, before 10 or 20 doses of factor VIII are given. In about 3/4 of these patients, if you do something called immune tolerance induction, ITI, and this will come up occasionally in our discussion as patients we're not talking about so much today, you can eradicate these inhibitors, and they can again get factor VIII. In about 5 to 7% of patients, you have sustained high-level inhibitors and factor VIII can't be used for bleeding, for treatment of acute bleeding, and it can't be used for prophylaxis. Until now, patients who had inhibitors to factor VIII were treated with bypassing agents. These are agents that bypass the gap in the clotting cascade by getting below where the action of factor VIII would be. And we're talking about two drugs, basically. One is activated prothrombin complex concentrate, APCC, FIBA, factor VIII inhibitor bypassing activity, FIBA. And the other is recombinant activated factor VII, NOVO7. These both can be used to treat acute bleeding, and they both can be used for prophylaxis, although only APCC has an FDA indication for prophylaxis, but they do both get used. Prophylaxis is burdensome. These factors are administered intravenously. They have to be given frequently. If we're talking about factor VIII, it's at least multiple times per week. And if we're talking about using a bypassing agent for prophylaxis, it's even more frequent than that. Venous access can be difficult in anybody, but particularly in young children. We're talking about self-administration of therapies at home. Elderly patients and patients who develop arthropathy may find it difficult to do self-administration. Not surprisingly, adherence is a substantial problem. Upwards of 50%, maybe 50 to 70% of patients who would be recommended to be getting prophylaxis do not get it or do not adhere to it. We have representatives of the patient community and clinical experts who can describe much better than I can the implications of all of this for patients and caregivers, but I just wanted to put up this chart that's in our report giving a sense of the range of things that are affected when you have severe hemophilia A. And the categories across the top are things that have bleeding risk, the requirement to be near specialized care, the requirement to have accessibility of your factors if you bleed or if you need them for prophylaxis, and flexible time. If you have a bleed a few times a month or your child has a bleed a few times a month, you need to have either work or schooling that's flexible around that. And this is just a chart giving some sense. So, for instance, that bottom line of recreation, if you have severe hemophilia A, maybe you don't want to do rock climbing. Maybe you can't move where you want to go and do recreation where you want to go because there's no specialized care nearby. Maybe you can't do a trip that takes you away for a long period of time because you need factors with you and there's only so much factor you can bring. So coming back to our clotting cascade and looking at what's going on, I'm going to try to use a pointer here, right here with factor VIII becoming factor VIIIa, bringing together factor X and activated factor IX. And into that space comes Hemlibra, which is a bispecific antibody, bridging these two factors. It's a weekly subcutaneous injection. It's used only for prophylaxis. So we're talking about a therapy that can be used for prophylaxis in patients who have inhibitors to factor VIII. The scope of our review is adults and children with hemophilia A with inhibitors who won't be treated with ITI, with immune tolerance induction, or for whom ITI has been unsuccessful. We're looking at prophylaxis with emicizumab, and we're comparing it to prophylaxis with bypassing agents and to no prophylaxis. This is just prophylaxis we're talking about. If you have inhibitors and you bleed, you still need a bypassing agent to treat that acute bleed. There are basically two trials of emicizumab. First is the HAVEN-1 trial, conducted in adolescents and adults. It is an open-label trial, and it's a before-after observational study. The trial portion was a randomized 2-to-1 comparison between emicizumab and no prophylaxis in patients with no prior prophylaxis. 53 patients, 35 in the emicizumab arm, 18 in the no prophylaxis arm. It also was an observational study of 49 patients who previously were getting bypassing agent prophylaxis and were observed during that time, and then enrolled to get emicizumab and observed on emicizumab. The Haven 2 trial. This is mostly younger children. You could be up to age 17 if you were very small, but most of the participants are less than age 12. It's an ongoing single-arm study. We have comparative before-after data in 23 patients and some other data in 57 patients. Again, ongoing study. Results have been presented at meetings and in other ways, but we do not have any published data from this yet. These patients required prior treatment with bypassing agents to be enrolled. What did these trials show? So here's a big box, but I want to focus on one piece at a time. So first, this is the randomized portion of Haven 1. We're looking at annualized bleeding rates, so the average number of bleeds per year, essentially. And we have this distinction between treated bleeds and all bleeds, treated bleeds presumably being the more important bleeds. And so, for instance, we see about 23 average bleeds per year on no prophylaxis and 2.9 on emicizumab for a relative risk of 0.13, or an 87% reduction. And again, that's a randomized comparison. If we move then down to the before-after combination in Haven 1 for the bypassing agents, if we look at, we're going to look just at treated bleeds here, at the 55-week data, for instance, on bypassing agents. The reason it's the same here and here is this is the before portion. So they were seeing 15.7 bleeds per year, down to 2.1, or again, an 87% reduction. But this isn't a randomized comparison. This is observational data. Similarly, in Haven 2, we have a before-after comparison. During the before period, in patients who were getting bypassing agent prophylaxis, we were seeing 17 about bleeds per year, down to 0.2, a 99% reduction in the before-after. But we're talking 23 patients here. This is the 57-patient portion, and this is the percentage of children who had no bleeds on emicizumab during Haven 2. So, for instance, if we look at treated joint bleeds, we see that 56 of the 57 patients, or if we look at all treated bleeds, we see that 54 of the 57 patients, 95%, had no bleeding up through the period looked at in Haven 2. Again, ongoing trial, these data are going to change. So, how do we compare emicizumab with bypassing agents? And this is relevant in part to how we thought about what to hand off to the modelers and the modeling you're going to hear later for what a fair comparison would be. This before-after look is likely to be biased. Patients aren't that adherent. During the observational portion, where they were getting what they were always getting, adherence may have been an issue. And so just looking at the intra-patient comparison before-after has risks of bias. That said, you could see the dramatic results in some of those cases. I'm not suggesting that all of that would go away, just that that may not be the most fair comparison. There are some prior randomized trials of bypassing agents. The bleeding outcomes in the current trial and how bleeding was assessed is not perfectly comparable with the older trials, but taking that in mind and looking as we did at this, we felt that of the 3 trials of bypassing agents, the best risk reduction was seen in the proof trial, Antunis, with a relative risk of median annualized bleed rates, which we used as an estimate for relative risk of mean annualized bleed rates so that we could compare it to that 0.13 that we saw in Haven 1, was 0.28. So that was a number that we thought was a fair representation of what bypassing agents had shown in a randomized trial. It was the most favorable number we could use for the bypassing agents. The Haven trials also looked at quality of life. Emicizumab improved quality of life compared with no prophylaxis in Haven 1, and in the interim reporting compared with baseline in Haven 2. It improved caregiver burden and appeared to improve attendance at daycare, school, and work. There were 3 trials of the bypassing agents that examined quality of life and did not show a statistically significant improvement in quality of life. What about harms with emicizumab? Injection site reactions are common. Of course, infusion site events occur with the bypassing agents as well. However, in Haven 1, there were 5 events that raised concerns of thrombosis or thrombotic microangiopathy. Thrombotic microangiopathy, clotting in the vessels, occurred in 3 patients, cavernous sinus thrombosis in 1 patient, and skin necrosis and superficial thrombophlebitis occurred in 1 patient. This obviously raised concerns. All these events occurred in patients who were getting emicizumab in Haven 1 and at a time of bleeding received high doses for a couple of days of APCC, one of the bypassing agents. It wasn't seen in patients who received the other bypassing agent, for what that's worth. This resulted in a boxed warning on its label for emicizumab and recognition throughout the community, both of providers and patients, of this concern. And to date, at least as we've heard reported, no similar events have been seen in Haven 2, and with this recognition. I think this is an issue that the experts will be able to speak to more to the extent you have concerns. What are some controversies and uncertainties? Well, lack of long-term safety data. We heard in the last 2 or 3 days reports about a total of 5 patients, one of whom was in Haven 1, who have died while receiving emicizumab. The reports have suggested that there was no connection between emicizumab and the deaths. There were patients who were getting it for compassionate use, patients who, one patient who had major surgery and died. But this is recent information and shows the concerns anytime you have a new therapy. So be aware that those data are out there, although to date we've been hearing that most people who have heard about this think that these were unrelated. I suspect more data will be coming along and more information will be coming along. What about safety in clinical settings that affect or require coagulation? Again, we only have small numbers of patients total who've received this agent. What if you get septic while you're on emicizumab? What if you have a major trauma while you're on emicizumab? What about lines, cardiac valve replacement, things like that? We don't have that much experience in lots of different settings. Again, we have only observational data comparing emicizumab with the bypassing agents. And for an uncertainty in the other direction, we have no data on reduced joint damage or reduced mortality. We're seeing reduced bleeding. We know that patients who have inhibitors have higher mortality relative even to other patients with hemophilia. But we don't have long enough data yet to know whether emicizumab, by reducing bleeding, is reducing mortality, is reducing joint damage, although we might expect that it would. You're going to be voting on other benefits and contextual considerations. I wanted to highlight a few off the longer list that we've given you that were stressed to us. One is that the notion of enhanced career and education choices. If you can take people who are requiring very frequent prophylaxis and are having frequent bleeding and make them bleed less, they may be able to alter their career and education decisions. The reduced burden of therapy. There's clearly reduced burden of therapy with emicizumab. We're talking about an injection given once a week versus intravenous infusions given often daily. And then past iatrogenic harm. This is an unusual contextual consideration, but in the 1970s and 80s, factor was contaminated with viruses, particularly HIV and Hep C. It's thought that 90% of people with hemophilia were infected and about half of people with hemophilia died. So this is a group that has suffered iatrogenic harm, and as we think about what society might be willing to pay for therapies for this, we thought this might be an important consideration in some settings. We received a number of public comments. We received a comment that we should have compared the bypassing agents based on their Haven 1 intrapatient comparisons. I explained to you why we thought we had concerns about bias of those observational data, and so looked more at prior randomized trials. Long-term safety of emicizumab not being known relative to APCC. This is true. We have far more data on APCC over many more years than we have on emicizumab. That we have inadequate comparative evidence for APCC. This is sort of the converse of bullet 1. We thought we picked the most favorable bypassing agent numbers we could pick from the randomized trials that were out there, rather than using the more dramatically better numbers that you would get if you did the intrapatient comparisons in Haven 1 and Haven 2. And then that there's no high-quality evidence that APCC and activated factor 7, recombinant activated factor 7, the two bypassing agents, are equivalent for prophylaxis. This is relevant to some of the modeling, and you'll hear how the modelers dealt with this. This is true. We have one small randomized trial suggesting that they're similar when used to treat acute bleeds. They've never been studied head-to-head for prophylaxis. So in summary, some concerns about safety remain. Efficacy is clearly much greater than no prophylaxis. Efficacy appears to be much greater than bypassing agent prophylaxis and is clearly much less burdensome. We felt that for the comparison of emicizumab and no prophylaxis in those 12 and older, that we had high certainty of a substantial benefit of emicizumab. For those under 12, we don't have randomized trial data. We felt that we had high certainty of a smaller substantial benefit. And for emicizumab compared with the bypassing agents, for patients of all ages, given the lack of randomized comparisons, we felt that we had high certainty of a smaller substantial benefit. But the only place where we thought we had high certainty of a substantial benefit was versus no prophylaxis in the older patient group. I'll stop there if you have questions. Yeah.
Yeah, so we'd like to open this up to members of the CEPAC panel for questions for Dr. Wren.
Could you please elaborate a little on the differences on bleeding evaluation between the newer and the older studies?
Sure. So in the newer studies, and we can turn to our experts to some degree, but in the Haven trials, people are carrying around smart devices and are marking when they think they've had a bleed and when they've treated the bleed. I suspect that that would have captured more untreated bleeding events. A concern was raised by one of the manufacturers that the barrier to treating bleeding has changed, and that patients are told not to treat bleeds as quickly now as they were in the past. I don't know whether that is a fair characterization. And also remember that Haven 1 is open label. All these studies were open label. So you might imagine that if you knew you were getting a prophylactic agent that you thought was effective, and you had pain in a joint and you weren't sure whether it was a bleed or not, you might be more likely to decide it wasn't a bleed if you knew you were getting an active therapy at that time. I suspect that would have applied to the earlier trials as well. We have much less good reporting of how bleeding was captured in the earlier trials. When we looked at them, we couldn't even perfectly tell whether they were reporting treated bleeds, although as we dug into the information, we concluded that they were reporting rates of treated bleeds.
Thank you.
Do we have a comment or question from our members of our expert panel?
I would maybe comment just about bleed management and hemophilia in general. So for a patient who's treated what we used to call on demand, so they're not on any prior prophylaxis, and I'm talking inhibitors or non-inhibitors. Patients have always been encouraged to identify their symptoms as early as possible and then to intervene with whatever the appropriate treatment agent is. So for a non-inhibitor, that would be to give factor VIII. If it was an inhibitor, whatever bypassing agent the patient had been prescribed for home use. So it's sort of a mantra of treat first and ask questions later, because we know that getting the bleeds under control early helps achieve cessation of bleeding and preserves hopefully the joint from significant damage from having a very large bleed. The paradigm shift with the current therapies is as you move to something that gives a steady state hemostatic benefit versus the traditional, what we call peaks and troughs of traditional prophylaxis. So when you do regular prophylaxis, for factor VIII, we're talking hemophilia A, that's every other day infusions. So you get an immediate peak right after the infusion, and then very quickly you're losing factor level on an hourly basis. And over a 48-hour period, patients drop to levels that are probably below the hemostatic protection from most traumatic injuries. So if there is early symptoms of a bleed, the patients are prompted again to give an additional dose of factor to try to intercept that bleeding. That's probably the same approach that's been used with bypassing agent prophylaxis. We know that there's a peak and a trough related to those agents. And so the inhibitor patients, for years we've been using bypassing agent prophylaxis, again, has been sort of as soon as you have symptoms of a bleed, you should treat with a bypassing agent. So I would say there really isn't a concept of untreated bleeds in the inhibitor population during the bypassing agent era, because unless it was just minor mucosal bruising, etc., something like that, bleeds really do pose a major risk for an inhibitor patient, and so the patients have always been taught to treat immediately. The paradigm shift now with an agent that achieves a steady state level is that there now is a more constant hemostatic benefit for that patient that's in the background. And I think clinically the treaters are learning how to use these agents to recognize that when there's trauma, there may be initial symptoms of bleeding, but because of the background activity of the agent, if it's minor bleeding, often there's enough hemostatic benefit on board from the Hemlibra that it arrests the bleed without the need for any additional hemostatic agent. Very difficult in the clinical trial program to tease out whether there was a change in practice of how bleeds were managed in that scenario that I just presented to you. I'm sure they've tried to tease that out from the clinical trial data, but I don't think you see any difference in the number of reported non-treated bleeds before and after the risk mitigation was put in place. I suppose some deeper analysis probably needs to be done in that regard, but I just wanted you to appreciate that having a steady state agent in the background providing hemostatic benefit does alter at least how we think and approach some manifestations of bleeding in this patient population.
Yeah, and I think that's great. And I would just add that as you grow older with this disease, you are more likely to have chronic disability and chronic joint damage, which for the average patient and many of the providers is difficult to distinguish. So if you're now getting a hemostatic agent and your joints hurt or ache, it may be difficult to tell the difference. However, with time you will know right away that it may resolve with no further treatment. So some of these are even retrospectively looked at in clinical trials. So I think it's about as accurate as it can be.
Thank you. So I don't personally have an inhibitor, but I was born at a time even before clotting factor was discovered, and I spent my childhood in a wheelchair and with braces, and fortunately modern medicine and corrective surgery on about 9 joints. I'm what you see today. But I think it is important to recognize that bleeding, it is a PRO. It is a patient-reported outcome. It is the patient that has to make a subjective, sort of qualitative decision on is it a bleed, is it pain, and make a decision to treat or to call the clinician. So that's imprecise. There have been studies that even have looked at patients and clinicians correlating that, and we both get it wrong, absent actually an ultrasound or something to detect bleeding. So I'm not sure that old data is good, bad, or indifferent. There's a lot of reasons why I would have skipped treating before, the burden, the timing, access to treatment, and so that might be an untreated bleed that maybe should have been treated, or in the future just the ability to have to get to the treatment center and to manage that bleed. So while I think the ABRs are an indication, they are imprecise, and those are the other metrics that actually are maybe more patient-relevant endpoints, probably add better color in terms of what the benefit of the treatment is than just looking at a quantitative number of really a subjective qualitative experience.
Thank you. Jason?
A couple of questions. I think one thing I'd like to try to struggle with a little bit is how to interpret the Haven 2 trial, because on one hand, there's an effect estimate that really is massive. It's 97%, or 99%, excuse me. So it's a really massive effect estimate in a non-randomized analysis. So I'm trying to understand and articulate the potential for bias and the directionality and magnitude of the potential bias in the analysis. So am I correct to say that in Haven 2, people on Emmy were compared to themselves before Emmy, sort of a pre-post analysis?
In the 23 patients that you're seeing that relative number from, yes.
As opposed to the 57, which is...
So not all, as I understand Haven 2, not everybody had gotten bypassing agents at some point, but not all of them were on prophylaxis during that pre-period.
Got it.
And so the 23 were ones who had been on prior BPA prophylaxis compared to how they did during the Emmy period, I believe.
Got it. Okay. And then this is a question sort of for the whole group. I guess, are there any potential sources of bias in that we should consider in the way that the trial enrolled patients? For example, were people more likely to be enrolled if they were having terrible bleeding, and therefore regression to the mean might be an issue? Are that type of issues?
I think as an information, we were desperate for some kind of hope.
Yeah.
We didn't have much choice in treatment. We didn't have much hope in that bypassing agents would always treat bleeds. So I would say there was some bias. We were anxious to try something new that might be potentially beneficial.
You could argue that giving a drug subcutaneously might bias you no matter how you felt afterwards. But the bleeds that these patients sustain are really painful, difficult. And so while it might have made the infusion easier to use a subcutaneous dose as opposed to standard IVs, there would be no question that there was an improvement in their joints after they had this. I mean, I think it's a yes-no.
Okay. Claudia?
I have a question for the clinical panel. I'm curious to know how many of the patients, both children and adults, receive port implantations for giving intravenous therapy?
From the clinical review that Dr. Rin presented, you may have appreciated that immune tolerance induction is sort of a mainstay of our attempts to eradicate inhibitors. Typical immune tolerance regimen requires high-dose factor VIII to be administered, usually daily. There are some other regimens that have been used, but a daily intravenous infusion for almost all patients has mandated the need for a central access, like a port. And so since many of these patients would have previously had some attempts at ITI, they weren't allowed to be on ITI during the trial. So the patients who enrolled in these trials, either they had forgone ITI or they had been, most often, they were refractory patients. They'd had a trial of ITI and then they went on to this trial. So many of the patients had ports. I believe that the number of patients with ports was documented in the clinical trial report. So I think that's available in there. As far as we have observed, there have been no thromboembolic events related to the ports themselves. But it'd be very difficult to tease out because of all the prior therapy that had already existed for these patients before they came into the trial.
Thank you. At this point, let's move on to a review of cost effectiveness. Welcome, Greg Gazauskas.
Hi, I'm from the University of Washington in the Comparative Health Outcomes Policy and Economics Institute. My colleague Lata Stuten and I did the cost effectiveness analysis. Other than the support that the University of Washington receives from ICER to fund this research, we don't have any conflicts of interest relevant to report for this. Our objective was to estimate the cost effectiveness of emicizumab as prophylactic therapy for hemophilia A patients with inhibitors to factor VII using a decision analytic model. And so this is just going to be sort of a drive-by look at the methods. There's much more detail in the report. Excuse me. So our comparators were emicizumab prophylaxis, bypassing agent prophylaxis, and no prophylaxis. We looked at this in children under the age of 12 and adolescents to adults over the age of 12. We built a de novo Markov model set in the United States using a payer perspective, a lifetime time horizon, and we discounted all costs and health outcomes by 3% per year. We decided to use a weekly Markov model cycle just to capture the frequency or the potential frequency of bleed events over time, particularly in patients who don't receive any prophylaxis that can potentially be fairly high. So we wanted to be able to capture all of those outcomes and the costs associated with them. Our primary outcomes were lifetime cost, quality adjusted life years gained, total bleed events over a lifetime, and then incremental cost effectiveness ratios, which is the cost per quality adjusted life year gained. This is our model schematic. It's an overview of how the model works. Up top, we've got in green our arthropathy submodels. So we divided patients into these submodels depending on the level of arthropathy that they came into the model with, and this is based on the Haven 1 and 2 trials. Patients over time, as they have additional joint bleeds, they develop additional arthropathy in their joints, and so we're moving patients from left to right, but patients don't go backwards in this. Within each of these arthropathy submodels, we have equivalent bleed health states that the patient can transition to and from at any point during each weekly model cycle. Our modeled health states are no bleed. We also have untreated bleed, which we essentially treated the same as no bleed. There was no cost or disutility associated with untreated bleeds. A patient could also have a treated bleed not into a target joint or a treated target joint bleed. And each week, within each of these submodels, depending on the patient's arthropathy, a patient could move from one state to the other. Or ultimately, since it's a lifetime model, all patients eventually die over time. Due to a lack of data in the clinical trial data that we've got for this, we had to make a number of assumptions just to fill in some of the gaps. The first is that bleed event rates are equivalent regardless of arthropathy severity, and this is just because we didn't see any differences in the clinical trials that were reported. We assume that bleed rates transition from Haven 2 to Haven 1 estimates once a patient turns 12. So up to age 12, we're just using the Haven 2 estimates, and then immediately once the patient turns 12, while we're modeling out the lifetime, it transitions into Haven 1 estimates of bleed event rates. We assume that 2-day bleed disutilities, we assumed that the disutility of a bleed lasted for 2 days, and then that was followed by an average of the bleed disutility and no bleed utility for the remaining 5 days of each cycle. And this is potentially a conservative estimate because we heard from some patient groups that the impact on quality of life can potentially last well beyond a week for some bleeds. So this was actually favoring the strategies that had more bleeds compared to strategies that had less. We assume that treatment adherence was 100% for emicizumab prophylaxis and 88% for bypassing agent prophylaxis based on the Haven and Proof trials. This is because obviously we've got short-term follow-up We did have to make this assumption throughout the entire time horizon of the model. So, and we assumed that the efficacy rates for bleed events was the same throughout, and it was baked into these adherence estimates. So the adherence is really just governing the cost calculations in our model. And so in that sense, emicizumab is biased against because it's getting the full cost throughout the whole lifetime, whereas bypassing agent prophylaxis is getting the reduced cost at 88% throughout the lifetime. Lastly, because we didn't see any mortality differences reported in the trials, we assumed that there was no mortality difference between any of the comparators. So this slide and the slide after this, I think, are probably the two most important for us to consider, and they have the most impact on the results. There's a lot more detail into how we derived the bleed events to move patients around in the Markov model over time, but these are the estimates that we use throughout the model. We've got emicizumab prophylaxis under the age of 12 and over the age of 12 on the left, and then we can see that bypassing agent prophylaxis was approximately 2 times as many bleeds compared to adults on emicizumab prophylaxis. And then patients who don't receive any prophylaxis at all have a much higher rate of bleeds each year. And so those clearly add up over a lifetime. Next is the other important slide, which is the modeled weekly drug costs. And I've got it at various ages here because in our model, if a patient enters the model at age 5, it's a small human, and then by the time they're 40, they turn into a much larger human. And all of these drugs are linked, or the regimen is based on weight. So the larger you get, the more drug you need. And so I'm showing ages 5 to 40 here. And as you can see, the prophylaxis costs, which are to the left of the dotted line there, are pretty substantial even for emicizumab per week, and this is per patient per week. And then if you look at bypassing agent prophylaxis, it's just remarkably higher. We're talking 8 times higher than emicizumab per week for prophylaxis, and that probably has a lot to do with the daily or every other day regimen of prophylaxis, whereas emicizumab is once a week. Also, obviously, the drug costs play a role here. To the right of the dotted line is the cost per bypassing agent treated bleed. So every time a bleed occurs, a patient faces potentially $60,000 or more cost in bypassing agents to treat that bleed. And so I think the two takeaways from this slide are that emicizumab and bypassing agent prophylaxis are both expensive. Bypassing agent prophylaxis is much more expensive. And then for every bleed that is prevented, there's also a substantial cost savings possible there by preventing that bleed in the first place. We weighted each of our health states by utilities that we found in the published literature. So at baseline, patients enter the model. If they don't have any arthropathy and they're not in a bleed health state, they have a utility of 0.82. If they have a treated bleed that's either not into a target joint or into a target joint, they have substantially reduced utility during the week that they're in that health state. And then based on the level of arthropathy, which you'll recall from the submodels in the Markov model, depending on their Peterson score, which is a radiological tool for assessing arthropathy in these patients, their utility declines over time as their arthropathy worsens. And lastly, patients whose joint arthropathy gets to be so bad that they need some orthopedic surgery to correct it, we assess a 1-month disutility of negative 0.39. All right. So as you can see in our results, these are our lifetime health outcomes, and emicizumab prophylaxis leads to fewer bleeds and more QALYs compared to bypassing agent prophylaxis and no prophylaxis. the life years are the same in both because, as you'll recall, we're not assuming any mortality differences among the comparators. When we look at lifetime costs, the differences are even more stark. It's surprising because emicizumab is, potentially $20 million for a lifetime, which is one of the more expensive costs I've ever seen in economic analysis of this sort. But it really pales in comparison to the bypassing agent cost of prophylaxis over a lifetime, which is approaching $90 to $100 million. And then no prophylaxis is also more expensive than emicizumab prophylaxis. So I think what's driving these differences, the difference between emicizumab prophylaxis and bypassing agent prophylaxis is really driven by the cost of prophylaxis each week. Since the efficacy is not as different compared to as the comparison between emicizumab prophylaxis and no prophylaxis. In that latter comparison versus no prophylaxis, the difference is really driven by the prevention of bleed events that emicizumab is providing. And so that's why we're seeing these results. So emicizumab, compared to the other two comparators, has fewer bleeds and a greater number of QALYs, and it comes at a substantially reduced cost. Usually in this last column we would calculate, the ICER, which is the incremental cost effectiveness ratio, but when the treatment is more effective and less costly, we health economists just call this a dominant treatment strategy. And we make no comment on the degree of how dominant it is. It's just a dominant strategy. We tested this in probabilistic sensitivity analysis. This is where we're varying all of our model parameters over thousands of simulations and seeing how often we get the same result. For 80 to 90-something% of our simulations resulted in a dominant result for emicizumab, and then the few that weren't dominant at various cost-effectiveness thresholds, our willingness to pay thresholds, the result was also pretty robust change, occurring in at least 93% of simulations. And compared to bypassing agent prophylaxis, it was at 100%. We ran a number of scenario analyses that are in the report. I don't want to go through all of them right here, just to list them and say that they were all the same result, which was that emicizumab was cost-saving or dominant compared to the other two comparators. I will mention this one. We received comment from the manufacturers that, or we thought that it might be a good idea to look at, well, what if we disadvantaged emicizumab and favored bypassing agents? And according to a number of concerns that were raised by some of the manufacturers in our calls, one of the things that we did was we made it so that prophylaxis and on-demand treatment for the BPA prophylaxis comparator was only with the lower cost APCC. For the emicizumab comparator, we set the on-demand treatment with bleeds to the more costly recombinant factor 7 only. And then we set all of the bleed event rates equivalent to the all bleed rate, which is higher than the treated bleed rates from Haven 1 and Haven 2. And then we kept some of the same estimates that we did in the base case that were bypassing agent favorable, which including our assumptions about lifetime adherence, and we kept the adverse events as they were for emicizumab. And then we also reduced the disutility of bleed events in this scenario just to make the penalty of a bleed less over time. Even despite all of these factors, emicizumab was still dominant versus the BPA prophylaxis strategy. Our model had a few limitations. The first, just modeling long time, lifetime outcomes based on very short-term data. So that you're making a big leap, I guess, saying that a trial that maybe lasted a few months or up to a year the results are going to be the same throughout a lifetime. We had a lack of long-term data on the development of arthropathy by treatment strategies, so we had to look to outside sources. We received some comment from experts that our use of the Peterson radiological score was perhaps a little outdated, but we didn't get any major feedback that it was necessarily wrong either, so we kept it. Lastly, the prophylaxis adherence is based on clinical trial data, and obviously we can't expect the controlled environment of a clinical trial to be the same in the real world. Some comments that we received during the comment period. The first is that we should use consistent sources for drug price to ensure fair and balanced comparisons, and this comes from the fact that emicizumab is new, and all we have thus far is a wholesale acquisition cost, and so that's what we used, whereas the bypassing agents, we had access to average sales prices, which were a discount from the wholesale acquisition cost. So this is further, bypassing agent favorability, but we still use this cost nonetheless because it was all that we had for emicizumab. Second, we were asked to evaluate APCC and recombinant factor 7A as two separate bypassing agent comparators rather than combine the two. But we showed in the scenario analysis that I just showed that even when we did that, as well as a number of other favorable assumptions to bypassing agents, the result was still the same, that emicizumab was a dominant treatment strategy. So in summary, emicizumab is lower cost and more effective. It's a dominant treatment strategy compared to no prophylaxis and to bypassing agent prophylaxis. Our results were robust to sensitivity and scenario analyses in all cases, and our findings are just primarily driven by a reduction in lifetime bleed events and the associated costs of those bleed events. Thanks.
Thank you, Greg. Now I'd like to open up the discussion to the CEPAC panel for questions. Go
ahead. I was hoping to get your thoughts and the thoughts of the experts on mortality, because you didn't account for it. Of course, it's skewed this year since we are seeing the liver and the HIV, but I was hoping to get some thoughts about potential benefits of mortality, even though the studies did not evaluate that.
Sure. So we do account for mortality in the model for hemophilia patients. There is an odds ratio of death that is applied across the board to all patients. We didn't model it being different among the comparators, but I think it's safe to assume that if we were to have modeled it, I think we would have said that, more bleeds leads to greater mortality. And so whatever the treatment strategy that had the fewest number of bleeds, it's reasonable to think that it would have lower mortality versus the other two comparators.
Steve.
Thank you for the presentation. It's terrific. Question about the lifetime horizon for the model. If I understand correctly, you're locking in the prices of these medications for half a century and carrying it forward throughout the lifetime of these patients. Wondering about that and potentially innovative therapies to come to market in the next decade or two ahead that may provide some other alternatives. And so with those considerations, was there any thought to looking at the cost effectiveness over a shorter time horizon, 10 years, 20 years, for example?
I guess we considered looking at shorter time horizons, but I mean, it's standard to model these things out for a lifetime, assuming, because we don't know what the future is. And we did discount all costs and outcomes by 3% each year. And we did vary the cost of the drugs in probabilistic sensitivity analysis. So there were lower estimates and higher estimates in that. And despite those two changes, over time, we didn't see that it had a material impact on the results. But sure, another drug could certainly come on the market and displace these or drive the costs down, but it wasn't a factor in our analysis.
Jason.
I just had a couple of technical questions about the way that people would transition between disease states in the model. So I think you mentioned, but please interrupt me if I got this wrong, that patients, yeah, yes, exactly, thank you, that patients could not transition, I can see the directionality of the arrows, from, for example, 2 joints with arthropathy to 1 joint with arthropathy. Was that true? Because there were orthopedic surgery events. So I'm just trying to think. I was actually prompted by your comments earlier that surgery can relieve arthropathy. So why wouldn't orthopedic surgery change that disease state backwards?
Right, they could. It's a simplifying assumption. I mean, we really struggled, I think, the most at the beginning of the modeling process, figuring out how we were going to model arthropathy.
Yeah.
Just because there isn't a lot of data out there, and ultimately we settled on a simplifying assumption that you could only move from left to right.
Got it.
But yes, I think in reality there would be certainly some relief of getting the surgery, but did we model an improvement in quality of life after a surgery? No, we only modeled the cost for it.
Got it.
Thing. So mine are total joint replacements. So the joint itself is not improving, but there's an intervention to replace the joint. Or my ankles have been fused, so the joint's been removed and they're fixed. Yeah. So the structure of the joint is not going to improve. Perhaps the synovium or the other inflammation around it will improve with enhanced therapy, but the underlying structure of the bone and the arthritis, that is set in motion from the first bleed and is progressive, at least based on treatment today.
There's the cost of surgery, which is not trivial, and there's probably a bit less motion than he had before. So one could argue about quality of life, but the real issue here is pain, which is the indication for the surgery that would be.
These explanations are very helpful to me. It sounds like because there's sometimes not much improvement, that actually validates the modeling approach, that you didn't go back to another disease state.
Right. And I'd just also add that the arthropathy aspects of the model really, the impacts on the overall results were relatively small because it's really being driven primarily by the bleed rates and the costs of the drugs.
Chris? This is an excellent model, so thank you. Question to the expert panel. Is there a material difference in time to hemostasis with either of these regimens?
So it's important to remember that currently emicizumab is only used for prevention. It's only used as a prophylaxis agent. So there is no assessment in the trials about the time to resolution of bleeds except they were using bypassing agents to treat those bleeds if it was a treated bleed. So I don't know that there's any clinical trial data that's going to help us understand whether a bleed on a background of emicizumab has an improved course. Maybe that some of that granularity will come out of the secondary analysis of the clinical trial programs. But I think that is an important something distinguished about the mechanism of action of this is it's not used for acute bleed management.
And in addition, the drug is actually started at double dose for the first 4 weeks to hasten it to get to a steady state. But we don't have data on acute treatment.
Thank you.
And well, I'll just add that in our family situation, we have noticed improved bleeding reaction, I guess, on emicizumab.
We have time for one more question from the panel. Claudia?
The question I have actually has to do with limitations. As you noted, there's prophylaxis adherence with the bypass agents is based on the clinical trial data, and it seems from what has been said earlier to be significantly higher than real-world adherence. Could you clarify for me if you used more of a real-world adherence scenario for bypass agents, how that would affect the results?
So, the way that it's modeled is we're just using those adherence estimates to model cost, and we're assuming that the efficacy of the drug is baked in to that 88% for bypassing agents. real world, I would expect that if the adherence was lower, then not only would you see reduced costs, but I would expect that you would see reduced effect as well in those patients, and that would make the comparison worse versus emicizumab. And for emicizumab, I think that we're all expecting that adherence, while it might not be 100%, I think it can be pretty good considering it's subcutaneous and it's once a week, and these patients have a really severe form of the disease, and so I would think adherence is going to be pretty high there. So I would think that the results might even diverge a little further in the real world.
Can I just, go ahead. I think there is one other thing to think about on here. It's because I struggle with this as well. If I went to a once-weekly therapy versus every other day, I think it's important to keep in mind that on bypass agents, we're dealing with cycles of peaks and troughs and a half-life. And so the trough becomes critically important to the adherence quotient of whether or not there's actually going to be damage. Where you're dealing with a drug that produces a steady state, it doesn't immediately drop at the end of that week. So you may have a diminished level of protection, but you're not back at the baseline that you would be. So comparing them in terms of the harm that would come from either a delayed treatment or a missed treatment might well be different and is not an apples and apples